Hello everyone, welcome to my channel. Let's start with surgery today. My favorite unit is GIT in surgery and today's topic would be esophagus. I'll be making 4 videos on this topic which are GERD, achalasia cardia, tracheoesophageal fistula and Heller's operation. These topics are very important and short notes are asked on these topics in the university exams as well as these are very important from NEET PG point of view. Now before starting the video, please subscribe and like my channel. Now let's move on to the topic. I'm using my Marrow notes for the reference as these are very good. So now let's begin with the topic, that is GERD. Gastro-esophageal reflux disease. It means that there is reflux of the acid from the stomach to the esophagus. Now what are the factors which help in maintaining the patency in the lower esophageal sphincter? It usually occurs due to relaxation of the sphincter and the acid content of the stomach goes into the esophagus. Now what are the factors which maintain the patency? Okay, first of all, the length of the intra-abdominal esophagus should be between 3 to 5 centimeters. It is very important that the esophagus should be long enough so that the GERD doesn't occur. The angle of His should be there, the gastroesophageal angle. It should be patent. Now next is pinching effect of the right diaphragmatic crura. Now this is right diaphragmatic crura and this is the pinching effect by the diaphragm on the esophagus. And here we can see there is angle of His, the angle between the esophagus and the stomach wall. Now the least contribution is by the arrangement of the gastric mucosal folds, but it is a very important question, but that what contributes the least in GERD, that is gastric mucosal folds, and the length is also been a question in the past NEET exams. Now the factors which will predispose to GERD are if the length is less than 2 centimeters, if the pressure is less than 6 millimeters of Hg, if there is increase in number of transient lower esophageal sphincter relaxation. That means if the lower esophageal sphincter relaxes too frequently, it will cause the acid to reflux into the esophagus. Now what are the clinical features we see in a patient? The most common clinical feature is heartburn. What is heartburn? Why do we call it heartburn? Because it is a gastric disease, right? We call it heartburn because the patient feels retrosternal burning, that is behind the sternum, and the patient feels like the heart is burning. It is a misnomer. Okay. Next is water brash. Sometimes we feel that the acid content has come in our mouth and we feel a bitter taste in our mouth. That is water brash. There is pharyngitis, there is laryngitis, there is chronic cough we experience, there is wheezing, and due to acid there can be dental caries as well. Now only if the empirical therapy fails, further investigations are carried out. What is empirical therapy? We try to limit the acid production. We try to give medical management basically, and if that fails, so we investigate further. Now what are the investigations? The investigation of choice is an upper GI endoscopy. We do endoscopy for that. What is gold standard? It is a 24-hour pH monitoring, and it is only done when surgery is considered. Now equivocal, how do we actually do this? We pass a pH probe which is kept 5 centimeter proximal. For example, this is the stomach and this is esophagus. So we keep the probe 5 centimeter proximal to the gastro-esophageal junction. Now this probe will, the acid will touch the probe and this will give us a reading of the pH. The probe used is a Bravo 24 probe which is used to monitor 24-hour pH, and during this time we do not give the proton pump inhibitors or any prokinetic agents so that we can get the accurate results. Okay. Now Demister score is calculated and GERD is diagnosed with the help of this score. If the score is more than 14.72, then GERD is diagnosed. Or if the pH is less than 4 at almost more than 4% of the time, then we can say that the patient is diagnosed with GERD. Now how will we manage the disease. First of all, the empirical treatment of GERD is lifestyle changes. We'll have to do weight reduction, avoid certain foods such as fried food, fatty food, spicy food, mint or chocolates, and also citrus fruits because they are acidic. All these food items can worsen GERD. Now, these foods can relax the lower esophageal sphincter and worsen the GERD. Now, small frequent meals should be preferred because in this case, if the stomach is full with food and the acid, there are high chances that the acid will reflux. That's why we consider small frequent meals. Dinner should be at least 2 hours before sleeping. Medications should be proton pump inhibitors and prokinetic agents. Now, what are the indication for surgery? Patient who are not responding to the medical management, patient who are suffering from complications of GERD like Barrett's esophagus, strictures or cancers. What is Barrett's esophagus? Now here I have downloaded a picture. This is Barrett's esophagus. The lower part of the esophagus, the mucosal wall is all eroded. Now this is the normal lower esophagus where even the sphincter is closed, you can see. But Barrett's esophagus, it is open and the walls are eroded. This is one of the complications of GERD. Now GERD is associated with large hiatal hernia, patient wanting to give up medical management. Then we can consider surgery. Okay. So now let's study about fundoplication. What is it? It is done to restore the adequate intra-abdominal length of the esophagus. Now the length of the esophagus, we have studied that if less than 2 centimeters, it can be a risk factor for GERD. So it should be at least 3 centimeters. And we do fundoplication. It actually involves tightening of the diaphragmatic crura to prevent the reflux and wrapping the fundus around the esophagus in a shoe shine maneuver. We have to remember this name because this can be asked as a question in the exams. In this surgery, we also have to take care of the vagus nerve, we have to preserve the nerve, and we have to re-establish the angle of His. Now the types of fundoplication are complete wrap and partial wrap. Now complete wrap is the Nissen's fundoplication, that is 360-degree wrap. The most common early complication is pneumothorax and the most common overall complication is the gas bloat syndrome. Next is, in this syndrome, the fundus is wrapped so tightly that the patient cannot even burp. Instead, a partial wrap or a floppy Nissen's fundoplication is done. Now actually, we can see in this diagram that this is the esophagus, this is the stomach, and what we have to do is pull up the esophagus and restore its length and then wrap the fundus of the stomach around the esophagus in this manner, in a shoe shine maneuver, and then we suture it here. So this is basically fundoplication, and it is of two types. It can be a 360-degree wrap or it can be partial, that is 180-degree, or a 270-degree wrap, which are given different names. Here we can study that. Partial wrap, door 180 degrees, Topaz 180 to 270 degrees, and Belsay's mark 270 degrees anterior. Now Coley's gastroplasty. What is it? It is done in cases with esophageal shortening where the esophagus becomes short. This is the esophageal wall, and पहले ये यहाँ तक था लेकिन अब हमने स्टमक वॉल को स्टेपल करके इसकी लेंथ बढ़ा दिया. To increase the length of the esophagus, a Coley's gastroplasty is carried out where a linear stapler is fired and an adequate length of the esophagus is created, called as neo-esophagus. Let's move further. Newer modalities include polymer injection around the LES to tighten the sphincter. Higher recurrence rate, it is not preferred. So what do? We inject the polymer injection to tighten the sphincter. Now some other newer modalities are endoscopic radiofrequency ablation. It has good long-term results, but there is risk of stricture formation. There is Lynx device and there is MSAD, magnetic sphincter augmentation. In these patients, it is done in patients with minimal or no hiatal hernia. There are magnets put around the lower esophageal sphincter to keep it shut. Next is transoral incisionless fundoplication, that is tempo trial. that is done 270 degrees. It is an example of node surgery, that is natural orifice transluminal endoscopic surgery, which is an endoscopic fundoplication. You just have to remember the names, not more than that. Now, what are the complications of GERD? The complications are, number one is Barrett's esophagus, which I have already shown you the picture. Here also Marrow has given a beautiful picture. It is actually a metaplasia of the squamous to columnar epithelium known as specialized internal metaplasia. It is seen with patients with long-term GERD. It has increased chances of adenocarcinoma and there is presence of goblet cells in the lining. Presence of goblet cells is a pathognomic feature. Now, what are the clinical features? Similar to GERD, but it can also have silent presentations. The diagnosis is endoscopically, we diagnose it with the help of biopsy. There is a red velvety mucosa is seen. What are the types of Barrett's esophagus? A long segment is more than 3 centimeters, a short segment is less than 3 centimeters, and cardia metaplasia is microscopic Barrett's. These are the types of Barrett's esophagus. Next is chromoendoscopy. What do we see in this? It is done when the abnormal mucosa is not visualized. So we will use color. What color do we use? We use methylene blue dye. Also used in adenocarcinoma, it is used to recognize the abnormal cells. Next is Lugol's iodine is also used. Yes, Lugol's iodine is also used in squamous cell carcinoma, and narrow band imaging can also help us identify the abnormal cells. We have to find the cells. What does the histology we have to see? The histology shows goblet cells, and biopsy is done at 1 centimeter distance from all the quadrants. Okay. Now, what is the management? How do we manage Barrett's esophagus? It is done according to the Seattle protocol. The Barrett's esophagus. Now, this is very important. In this management, a 2-yearly endoscopic surveillance protocol with multiple biopsies is done. If it is Barrett's, continue endoscopic protocol, and if it is a low-grade dysplasia, so we'll ablate or destroy the abnormal mucosa. It can be done with two things, that is radio frequency ablation or photodynamic therapy. In radio frequency ablation, there is less stricture rates and 12 joules per centimeter square energy is used, and 6 monthly follow-up is required in both of these. In photodynamic therapy, we use argon beam photocoagulation, but this is always better. Now, high-grade dysplasia, in this we have to ablate abnormal mucosa. 3 monthly follow-up is done, endoscopy is done, and if there is cancer, then esophagectomy is done. Next is, once RFA is done, the abnormal lining is shed off and new squamous epithelium develops. Sometimes the abnormal cells are left behind and gets buried below the new epithelium. The abnormal cells gets buried below the newer epithelium, and these buried glands can develop into cancer. In such cases, we miss out the cancer. Other complications are stricture formation and cancer. So that's all. We have completed the topic GERD, and all I want to say is I would like to thank Marrow and Dr. Rohan Khandelwal sir, and also thanks to the audience who have listened to the lecture, and do subscribe and like the video. Thank you guys. Bye bye.